So thanks for allowing me to speak. It's always a pleasure, and I love this meeting, and I've been coming, I think, since almost the first one, Dave. In the beginning, I got to come just for fun, but now I work a little bit. So moving right in, I'm just going to talk to you about two things today because I know a lot of you have been here before. A lot of you have heard me talk before. So I'm certainly going to talk about who PCEC is and what we're doing. But I couldn't help but take advantage of this opportunity to share a pilot study that we did really during COVID over the last few months with primary care doctors, and I thought it was pretty intriguing. The data is small, and I'll jump into it, but I'm really looking forward to actually getting some input from you guys during this meeting and letting us know how we need to grow and expand this work. So basically what we did is, thanks to a partnership with Pfizer, actually, we were able to do a quick study on the primary care physician attitudes on PSA testing. And it's a small study, under 100 people. And we didn't grab a lot of information about who they were, and we didn't really dig in once they responded. So we're using this as a pilot study to determine if it was worthy of really investing more money and time into pursuing this a little bit more. And we were surprised by some of the results. So the first one was, we asked what their opinion was on screening and PSA testing. So the first question was basically, do you provide PSA testing in your practice? Only 80% said yes. Dave's talked to us for years about how 90% of the PSAs are done by primary care doctors, so we were really intrigued by the 20% who said no. And we don't know why. We didn't do enough digging into wondering why they said no. Maybe they only treat women, we don't know, but we were shocked by that 20%. Out of the people that said yes, we asked them if they felt PSA was a valuable test, and 68% said no, and the remainder said yes. Interesting from a primary care doctor setting. Dave, I can see you're already ready to say something. So then we asked if they used other tests, right? So we wondered if they used any other genomic tests for prostate cancer diagnosis. Out of all of them, only 2% said yes. However, oddly enough, we actually offered, once they said yes, we offered a list of testings and then allowed them we offered a list of genomic tests and then allowed them to write in their own if they had something else they were using. We got 0 responses in that space. So even out of the 2% that said they did use other tests, they did not clarify which tests they use. Again, I've been around for many decades, as has been pointed out several times today. So my jaded side is, I wonder if they're actually those 2% were being honest. Then we asked them to rank risk factors, and this is really just general knowledge to see how some of these primary care doctors rated. And interestingly enough, they did pretty good in the top 3. So out of all the choices we gave them, the top 3 rankings were race, family history, and obesity. Did not rank at all amongst the primary care docs we surveyed was BRCA, environmental issues like first responders, and then income level, which was also interesting for us from a nonprofit status. And then this was also, I guess, after all the many decades I've been working, a little discouraging to me. So we asked them what age they screen. So if a man comes in, they have no risk factors, at what age do you start screening? And the first 2 rankings, obviously 50 and 55. Then we asked them what age they screen men who might have some of the risk factors. And oddly enough, it didn't go down at all. We still had 50 and 55. Now in the data, actually some of it did switch a little bit. So there were more that geared towards 50, but it didn't have, there wasn't enough of those responses to actually change the first 2 rankings. So this is also an interesting topic. And again, keeping in mind, this is under 100 primary care doctors, but it was a national sample. And this certainly rose some concerns for us. And then we asked what the normal PSA value was to them. So we said, if you have a 65-year-old guy of average risk, what would you consider a normal PSA? And Dave, we did not offer 1.5 as a choice, but we bridged the gap there. So we did 0 to 1, that was 0%, 0 to 2 was 10%, 0 to 3 is 40%, and 0 to 4 was 50%. The good news is nobody chose 0 to 5. The bad news is that 0 to 4% still means that PSA report that they're getting is guiding a lot of what they're doing in practice. And then we, of course, we're an advocacy organization, so we asked this question: what % of patients actually initiate a conversation of prostate cancer with them? And as you would expect, 80% didn't at all. So for 80% of the physicians, less than 25% of the patients initiated that conversation. And then 25 to 50% was about 20%. Nobody ranked more than that. So this is also an interesting thing where clearly we have more work to do out in the community. And then lastly, we asked for patients that they're following in their practice who have been diagnosed with prostate cancer, what do they track? And these were the results we got. Some track their PSA, some rely on the urologist to do that, some track their testosterone, less track bone health, about the same amount track the CV health of these patients. The bulk of them actually only are treating patients for acute illnesses and aren't really involved in their prostate care at all. Interestingly enough, another question we asked was around their communication with the urologist or the local specialist, and only 12% felt like they had a robust enough conversation with them. So now I'm going to transition into a little bit about PCEC, and then I'm going to get to our ask, which will circle back to the survey. So for those of you that are new in the audience, as David mentioned, the Prostate Conditions Education Council, and it was a long battle to win to be able to do that, is a 501c3 nonprofit. It was founded by Dave and a bunch of other key opinion leaders back in the late 80s, before there was even a PSA test available. And it was really founded around what was Prostate Cancer Awareness Week at the time. It was an IRB-approved protocol and still is to this day. However, now we screen more than just in the week. We provide screenings year-round, and we were charged with founding Prostate Cancer Awareness Month many, many decades ago. So it's also, as Dave mentioned, one of the largest and most successful men's health screening programs in the world to this day. So we wanted to talk a little bit about some of the successes we've had. We've had a lot of questions about how do we provide screenings during COVID, and oddly enough, we were able to do that. We were able to pivot very quickly, and through a wonderful partnership with LabCorp, we're able to provide online screening forums, in-person discussions with patients, and then refer them to LabCorp for either in-home testing or to go into a lab as a single patient rather than going into a bulk screening event in a doctor's office. But some of the other tools we did is, honestly, with the support of MDX Health and their great ideas, we're able to provide resources to patients and to urologists around how to manage COVID for prostate cancer patients, how to manage them during COVID. And then we actually also did a great collaboration with a lot of different groups where we created a telehealth collaboration tool that was one of the biggest barriers for patients that were prostate cancer aged and getting into their physician and continuing their treatment. So what we did is worked with, we started with working with a lot of the urological societies around the country, and together we were able to create this educational piece that then was very quickly picked up by other advocacy groups in prostate cancer. But to me, the biggest benchmark of success is if it goes beyond our own silo and our own disease state, and it did. So this piece was picked up by all breast cancer groups and a lot of other cancer groups, including lung and colon. So that to me is one of the proud moments we had during COVID. We also have been hearing a lot about disparity. Every pharmaceutical company is interested in disparity, and of course it's been a key interest of ours for a long time. However, we define disparity groups a little bit different than some. Of course, there's the racial disparities that we all know, and certainly the veterans disparity that we've seen historically, but also with veterans of current conflicts. We now look at hereditary and genetic risk as a disparity requiring some extra touch, and environmental exposure, which happens to be one of the ones that we're very passionate about in our organization, and really one that we're curious as to why it really hasn't picked up. Firefighters specifically and other first responders have such a huge incidence of all cancers, including prostate cancer, at a very young age, and they're all insured. They just aren't getting good screening because, probably back to the survey, that they're just not being screened early enough. So this is an area where we do a lot of work. We provide a lot of testing events and a lot of education to firefighters and police departments around the country. We also look at socioeconomic status and, of course, rural populations. We're headquartered in Colorado, and we're kind of a mecca for a lot of the states around us coming in for care. So what is my ask of you guys today? I would not be a good advocate if I didn't come and ask you to do something. So we need to revamp Prostate Cancer Awareness Month after COVID, and we'd like for everybody to host something. We have enough programs for you, and we can customize them for each and every organization in this room. So whether it's doing a men's health event for patients or doing something in your pharmaceutical company for even your staff, looking at doing not only screening programs, but educational programs. We have a lot of opportunities for you to do digital outreach to everybody that you work with. Certainly, we have opportunities for you to provide educational materials to patients in your community, especially those that may not already be in your practice. And we'd like for you and your staff to really make it a big deal this year. And most importantly, we would really like to encourage each of you guys to reach out to your primary care partners. It's really important. We've seen already that the data isn't really reflecting what we think it should be at this point in time around prostate cancer. We have examples of best practices, and we'll continue to look for more that we can share. We're going to be working with some of the family practice meetings to see how we can start to gauge this better and maybe have a better impact. And we're going to be having educational forums in different spots around the country for primary care doctors to try and see if we can start shifting this. But the most important thing is the specialists that they refer to really need to work with them and help them understand what's going on in the prostate cancer space. That's it.